Hello, my name is Taylor Poyner. The title of this DNP project is Prevention of Surgical Site Infections in Patients Undergoing Vascular Surgery. My committee consisted of my DNP chair, Dr. Gordon West, who provided support and guidance throughout the entirety of my project. My community member was Carrie O'Brien, who is a physician assistant that works closely with me within my department. And lastly, though they were not members of my committee, two professors that I would like to give special recognition to for their contributions to my project and throughout my graduate nursing journey are Dr. Rita Wunderlich and Mark Pals. Their positivity and kindness to each of their students does not go unnoticed, and their names are worth mentioning, as without them, this project would not have been successful. Inexpensive, non-invasive preoperative protocols can immensely assist in the prevention of surgical site infections. The most effective step in prevention protocols is the instruction on and implementation of the standardized use of perioperative cleansing with chlorhexidine gluconate, or CHG, twice prior to admission for surgery. After review of the policies and procedures and protocols in the institution in which this quality improvement project took place, it was identified that this critical step was not being performed. A noticeable surge in postoperative groin infections among patients undergoing lower extremity vascular interventions was observed. Following extensive consultations with colleagues and the DNP chair overseeing this project, a gap was identified in the nursing education provided to outpatients in the vascular surgery department concerning the recommended use of antiseptic cleansers preoperatively. The institution had been persistently striving to optimize the care of surgical patients and offer preoperative prophylactic interventions over several years. Although the project institution had already implemented various measures to prevent infections in this patient cohort, the standardization of preoperative outpatient education about the use of CHG to be used twice before admission for surgery was identified as a potential solution to mitigate the complex issue of surgical site infections. The purpose of this scholarly project was to decrease the amount of surgical site infections in patients aged 18 and over undergoing planned vascular surgery below the level of the aortic arch. The proposed intervention for this project was for ambulatory vascular surgery nurses to provide patients education on the use of an antiseptic cleansing agent to be used at least twice prior to admission for surgery. Secondary aims included decreasing readmission rates and improving patient safety and satisfaction. The PICO question for this project was, in outpatients over the age of 18 undergoing elective vascular surgeries, how effective is providing CHG and associated preoperative education compared to not providing CHG or outpatient education in reducing the rates of postoperative surgical site infections developed within the first 30 days postoperatively? The articles found to support this project demonstrated four themes: surgical populations, risk factors for developing surgical site infections, multi-step preoperative protocols, and outcomes of the utilization of antiseptic products preoperatively. Studying the use of a specific preoperative cleanser amongst multiple specialties can assist in better delineating what specialties may require increased attention for the prevention of surgical site infections. This is important to consider as the length of surgery time increases the probability of developing a surgical site infection as much as 13 to 37% per additional 15 to 60 minutes of surgery time. As some vascular surgeries can take up to 15 hours, it is vastly important to provide all evidence-based means of infection prevention available to vascular surgical patients. Across all the literature reviewed, the use of CHG at home prior to surgery was identified as an effective adjunct to infection prevention approaches. However, it is also crucial to consider a multitude of other risk factors outside of skin flora that may also play a role in surgical site infection development. Each article included in the review had a specifically developed protocol for surgical site infection prevention, which was included cleansing with CHG. Additionally, adherence to protocols consisting of bundled interventions amongst the studies was a prevalent topic. There is evidence that supports a greater efficacy rate of infection prevention when cleansing with CHG the night before and morning of surgery. However, there were similar positive trends identified between variable time points of cleansing as well as only cleansing on the morning of surgery. Prospective randomized controlled trials are a gold standard in research. Several of the studies included in this review fit under this description of prospective research. In addition to this strength, the studies each included an adequate number of subjects to produce reliable results and required informed consent, which is essential to performing ethical research. Weaknesses in the literature related to clinical trials included variables such as age of the research, biases, lack of a control group, inadequate sample sizes, results that are not generalizable or statistically significant, and unclear methods, among others. One of the weaknesses identified in the literature for this project included some studies being greater than 7 years old. Another weakness identified was that some of the trials did not produce statistically significant results on the overall reduction of surgical site infections. There are bound to be gaps when reviewing multiple clinical trials that are intended to be linked to or relate to one group or population. Gaps identified throughout the literature included that most of the data reviewed was not specific to the vascular surgery patient population. In addition to this, there was no standardized form of patient education amongst all of the trials reviewed. One limitation of the research found included variables such as only culture rates being examined and not specifically reduction in surgical site infections. Another was that it is difficult to truly demonstrate a direct causal relationship between preoperative protocols and the reduction of surgical site infections if the study is not both randomized and controlled. And outside of these, limitations also include that other risk factors heavily influence surgical site infections outside of preoperative cleansing, and there is somewhat of an inability to determine exactly which aspects of certain multi-step protocols influence the reduction rate of infections. Lastly, some trials did not include details on the application of CHG itself, which is a critical component of its effectiveness. The purpose of this DMP project was to implement a change in protocol in the outpatient setting that would drive the improvement of outcomes following the interventions performed in the inpatient setting. Nursing change theories involve a multitude of factors that support changing particular processes. A change theory that well represents the implementation of the process change involved in this project was Rogers' innovation diffusion theory. This theory involves 5 stages which in essence explain how someone or a group of people move from having knowledge of a particular intervention or innovation to confirming the decision to adopt and maintain the idea. The 5 stages of Rogers' innovation diffusion theory are knowledge, persuasion, decision, implementation, and confirmation. Each of these 5 stages were followed and focused on throughout the course of this project. Research supports the effectiveness of the utilization of CHG products at home or directly upon presentation to the hospital for prevention of surgical site infections in patients undergoing elective surgeries. The preoperative protocols examined within the literature search for this project required different forms of preoperative cleansing. However, the results were encouraging despite differences between time of preoperative cleansing, form of CHG, number of uses, or how education was provided to patients prior to surgery. For this quality improvement project, participants were asked to use 4% CHG at home twice prior to surgery and to follow explicit instructions per the educational handout provided to them. The product was provided to the patients. Electronic medical records from the clinic were used for data collection. The data for this project was extracted from the EMRs of patients age 18 to 85 who underwent elective vascular surgery from April 24th, 2023 to August 1st, 2023. Active participants in the project were patients aged 18 to 85 who underwent elective vascular surgery from June 8th, 2023 to August 1st, 2023. The researcher determined whether or not the participants met the inclusion or exclusion criteria by performing chart review for each patient being scheduled for elective vascular surgery. After approval was obtained from Maryville University for this project to begin, data was collected from EMRs for patients who underwent elective vascular surgery from April 25, 2023 to August 1, 2023. Data was collected from those records and entered into a secure database which required 2-factor authentication for entry. To comply with HIPAA, data was stored on facility computers which required VPN access and passwords for use. All potential patient identifiers were redacted and the minimum necessary data was collected. For this project, data was collected as a ratio. To manage the data, the author collected the de-identified data and transcribed it into an Excel spreadsheet. The level of measurement was nominal, the independent variable was time, and the dependent variable was whether an infection occurred. The statistical test that was utilized for the project was a z-test with a difference of 2 proportions. An a priori analysis was completed, resulting in a suggested sample size of 154 subjects between both groups. This DMP project was intended to decrease the incidence of surgical site infections and improve patient outcomes. The project was designed to protect patients from harm with as minimal risk as possible, and the benefit of the project outweighed the intrinsic risk. The final results of this project provided a guideline to the facility for implementing a standardized process across all clinics within the institution who perform higher-risk elective surgeries. In the context of this project, descriptive statistics were employed to evaluate the demographic attributes of both pre- and post-intervention groups, which collectively encompassed a total of 155 patients, with 64 being female and 91 being male. The mean age of participants pre-intervention was 70, and the mean age of those readmitted was 74. Following the intervention, the average age of participants increased to 72, and the mean age of those readmitted was 73. The breakdown in procedure types was also collected in an effort to determine if there was a recognizable pattern. The most common procedures patients were readmitted after in the pre-intervention group were lower extremity angiograms and endovascular aneurysm repairs, of which both require groin arterial access. The fact that these procedures involve groin access could be a potential point of interest for further investigation into the causes of readmission. No discernible pattern was identified among the patients who were readmitted post-intervention. Given the retrospective pre-intervention design, the two samples represented distinct samples of different participants. Notably, this project excluded the collection of data on ethnicity, socioeconomic status, and other factors due to the belief that these variables would have minimal impact on the results. However, it is understood that these factors could play a role in the context of the study and may warrant further exploration in future studies. The data collected to assess the surgical site infection rate in both pre- and post-intervention groups underwent analysis using a lower tail z-test for the difference of two proportions. This specific test is a directional variant of the chi-square test designed to determine if there was a significant decrease in infection rates post-intervention. The null hypothesis posited that the difference in infection rates between the two groups was zero. A significance level of 0.05 was chosen to gauge the statistical significance of the observed differences. This approach enabled the investigation of whether the intervention had a demonstrable impact in reducing surgical site infections. For this project, a lower tail z-test for the difference of two proportions was chosen to determine the significance of the differences between the pre- and post-intervention groups. The pre-intervention group who did not receive adequate preoperative education or CHG in clinic had a statistically significant higher amount of readmission rates within 30 days postoperatively, 0.12 versus 0.05. The p-value was 0.0439, which was less than the significance level of 0.05. The confidence interval suggested a true change in ratio from pre to post-intervention. Since 0 is not included with the interval, there was significant evidence to show a change in one direction. The achieved power of the study was 0.5248, which is considered medium in strength. The project, while providing invaluable insights into the impact of preoperative education and CHG usage on mitigating surgical site infections and reducing readmission rates, was not without its limitations. Several factors could have influenced the results and should be considered to interpret the findings accurately. Some of these factors could include variations in patient compliance with the recommended protocols, potential differences in the surgical team's adherence to standardized procedures, and the possibility of confounding variables affecting the observed outcomes. The study was conducted in a specific clinic within the South Central region of the United States. The sample might not fully represent the broader population, limiting the generalizability of the findings. Factors such as geographic location, patient demographics, and clinic-specific practices might have influenced the results. Moreover, the reliance on electronic medical records for data collection introduced the possibility of measurement biases stemming from potential inaccuracies or incomplete documentation within the records. Furthermore, despite rigorous training and education, variations in the implementation of the intervention among nurses or non-adherents or patients could have influenced the observed outcomes, potentially compromising the overall effectiveness of the project. The longitudinal nature of the study, while essential for capturing the intervention's impact over time, could have been susceptible to the influence of changing clinical practices, staff turnover, or alterations in patient demographics throughout the project. Additionally, resource constraints, particularly concerning the availability and cost of CHG bottles, may have implications for the sustained application of the intervention beyond the project's duration. To mitigate these limitations, several steps were taken, including comprehensive training for clinic staff, meticulous data collection, and a standardized intervention protocol. A rigorous data analysis approach helped ensure the reliability and validity of the findings to the best extent possible. However, the inherent limitations may have influenced the study's results, potentially affecting the overall interpretation of the project's outcomes. The generalizability of the results is limited primarily due to the study's specific context. While the findings provide valuable insights into the efficacy of the intervention within the selected clinic and patient population, caution should be exercised when applying these results to different geographical locations or healthcare settings. The sustainability of the results hinges on the continued adherence to the intervention protocol and the availability of necessary resources, such as staff training and CHG supplies. However, changes in the clinic's operational dynamics or shifts in patient demographics over time might impact the sustainability of the intervention's effectiveness. Furthermore, the long-term financial feasibility of the intervention may depend on the cost-effectiveness of the implementation and its integration into the existing healthcare infrastructure. Thus, ongoing monitoring and periodic assessments are imperative to gauge the intervention's sustained impact and ensure its successful integration into routine clinical practice. Addressing these limitations would involve conducting larger-scale, multi-center studies encompassing diverse patient populations and settings. This could help establish a more comprehensive understanding of the intervention's efficacy and sustainability, leading to broader applicability within the field of vascular surgery and potentially improving patient outcomes on a more significant scale. Moreover, implementing more detailed and standardized data collection methods and incorporating advanced statistical analyses could offer deeper insights into the nuanced effects of the intervention, fostering a more nuanced understanding of its potential benefits and limitations. Additionally, fostering collaboration between researchers, clinicians, and policymakers would facilitate the development of improved or additional evidence-based guidelines and protocols for widespread adoption, ultimately enhancing the standard of care across various healthcare settings. The findings of this quality improvement initiative carry significant implications for various aspects of healthcare practice, policy, and research. From a practical standpoint, the demonstrated effectiveness of comprehensive preoperative education and providing CHD bottles to patients highlights the importance of incorporating thorough patient education strategies into preoperative care protocols. Providers can use these results to emphasize the critical role of patient education in mitigating the risk of surgical site infections and reducing readmission rates, thus improving overall patient outcomes. Additionally, future research could delve deeper into the specific components of preoperative education that yield the most significant impact on patient adherence and outcomes, facilitating the development of more tailored and effective educational interventions. From a healthcare policy perspective, these findings stress integrating standardized preoperative education protocols and accessible infection prevention measures into broader healthcare policies, promoting standardized care practices and enhancing patient safety across various healthcare settings. Moreover, recognizing barriers such as time constraints and cost implications highlights the importance of policy initiatives that support efficient resource allocation and adequate time allocation for patient education within clinical settings. Overall, this study contributes to the growing body of evidence supporting the critical role of comprehensive preoperative education in improving patient safety, thereby emphasizing the importance of implementing standardized protocols and policies that prioritize patient education and infection prevention measures in healthcare facilities. Surgical site infections are a significant concern in surgical procedures as they can lead to prolonged hospital stays, increased healthcare costs, patient discomfort, and in severe cases, even life-threatening complications. Effective patient education can mitigate these risks by empowering patients with the knowledge and tools necessary to actively participate in their preoperative care and infection prevention. Educated patients have a better understanding of the surgical procedure, potential risks, and pre- and post-operative care requirements. This enables them to make informed decisions about their treatment and follow medical advice more effectively. Patients who are educated about the importance of proper wound care, hygiene, and infection prevention measures are more likely to take personal responsibility for their recovery. They understand the significance of adhering to prescribed medication regimens, wound care techniques, and activity restrictions. A well-informed patient is more likely to recognize the early signs of infection, such as increased pain, redness, swelling, or discharge from the surgical site. Early detection allows for prompt medical intervention, potentially preventing the infection from worsening and reducing the need for readmission. Clear and comprehensive preoperative education equips patients with the knowledge needed to comply with postoperative instructions. This includes wound care, proper nutrition, physical activity restrictions, and medication management. Improved compliance can significantly lower the risk of surgical site infections. Surgery can be an anxiety-inducing experience for patients. Education can alleviate some of this anxiety by providing patients with realistic expectations of the surgical process, recovery timeline, and potential complications. Reduced stress levels can positively impact the body's ability to heal. When patients are educated, they become active participants in their care team. They can effectively communicate with healthcare providers, ask pertinent questions, and share any concerns, leading to improved overall care quality. Preoperative education isn't just about the immediate pre- and postoperative period. It also emphasizes the importance of long-term health management. Patients who understand the significance of maintaining a healthy lifestyle, managing chronic conditions, and attending follow-up appointments are more likely to prioritize their health and well-being. Lastly, patient education can contribute to improving health literacy, which is a fundamental skill for making informed health-related decisions. Improved health literacy translates to better overall health outcomes and lowers risks of complications. In conclusion, providing comprehensive education to patients before vascular surgery and giving them preoperative cleansing products like CHG is a proactive approach to reducing readmission rates for surgical site infections. By empowering patients with knowledge, fostering their engagement in the recovery process, and enhancing their ability to prevent complications, healthcare providers can significantly improve patient outcomes and contribute to more effective and sustainable healthcare systems. The favorable outcomes of this project will significantly influence my professional approach. I intend to consistently prioritize the implementation of small preventive measures to minimize the risk of long-term complications for my patients. Individuals under my care who avoid complications such as surgical site infections will experience enhanced engagement in their treatment and enjoy the advantages of proactive involvement in their care. Moreover, the broader healthcare community faces a pivotal decision regarding the adoption of straightforward and cost-effective solutions. Embracing such approaches not only benefits patients but also contributes to fiscal responsibility through reduced readmissions. Overall, this project was successful in reducing readmission rates due to surgical site infections. The only thing I would have done differently throughout the course of this project was to be more consistently communicative with my DNP chair. Recognizing his profound intelligence and valuable insights, I found his guidance particularly beneficial towards the project's conclusion. The DNP program at Maryville University has proven invaluable to my professional growth, and I am genuinely grateful for the comprehensive education it has provided me. I would like to allow you any time for questions, and truly, I thank you all for listening.